This is Advanced Patient Care Theory 2, Unit 3, Part 10, Gerentology. So let's talk a little bit about elderly patients who we encounter and with a couple of caveats. So I don't need to tell you that there's a gray tsunami happening, that baby boomers who were born between 1946 and 1965 are entering retirement, and the population is expected to, the elderly population is expected to explode essentially. 6.7 million retirees expected in 2021 and 9.2 million in 2041. Hey, just out of curiosity, do any of you know my retirement date from teaching, from everything, essentially will be 2025. Any of you know what your retirement date is? You younger people?
Not really.
No.
I get it in my hoop portfolio every year, but
Yeah.
I can't remember what it is.
Yeah. We'll start investing in your RSPs now. MJ, 2050? That's amazing. Yeah, baby boomers. I'm a baby boomer. Unfortunately, there are too many of us, and so I think our retirement's going to be a bit of a challenge in terms of money and in terms of care provided. So I'm looking forward to going into a nursing home and giving you guys a really hard time when you come to get me. Yeah, CPP might dissolve. Let's not get too pessimistic. But anyway, here's a couple of charts. Don't memorize this stuff. This is not important stuff, but just more of a curiosity than anything else. But you look at what's happening here from, say, 2011, the number of people over the age 85 from 2011 to 2041 goes up by about 10%, which is quite remarkable. And just another one for context here. So 2035, the people over the age of 65 is estimated to be at 24% compared to 16% in 2015. That's quite a jump. And increasingly, we're going to see people living at home. There's even some discussion amongst healthcare leaders about whether we even need hospitals anymore, or whether we should have silos of treatment centers and provide more care at home rather than institutions. So it'll be interesting to see what happens over the next 10 to 20 years or so. But some general principles around the elderly patients. So multiple diseases are the rule in the elderly patients, multiple medications are the rule. My observation has been that if the patient's on 5 or fewer medications by the time they're 70, there's a good chance they're going to live till they're 90 or more. If they're on 12 medications by the time they're 70, they're probably not going to live much longer. But that's just my anecdotal observation. So
medications are overrated, Rob. You got to go homeopathic. Stop everything all at once, and you'll live to your 100.
Go homeopathic, eh? I'm not sure about homeopathic, but maybe just stop everything. Okay. Do you genuinely believe that, or are you being facetious?
No, I'm being facetious.
Okay.
There was a patient in the ICU for 2 weeks, and the family brought a whole bunch of echinacea and garlic supplements and told the doctor to give it to him.
That's awesome. I love that little that little comic.
So it's gonna fix his sepsis.
Oh yeah. There was a meme or some sort of joke on Facebook. I can't remember what it's something like an elderly woman asking the doctor to prescribe euthanasia for her husband, and the husband saying that's echinacea, not euthanasia. Anyway, I thought that was funny. Alright, so patients, as you know, frequently fail to relate symptoms, have difficulty verbalizing what their symptoms are, and there are lots of sensory alterations. Obviously, we always assume that the hearing is perfectly fine until they don't hear us, and then we might talk a little bit louder. And a lot of elderly patients have a fear of medical care and hospitalization, and certainly can't blame them. I don't know that going to the hospital is always in the best interest of these patients, to to be exposed to all those additional pathogens. And of course, a cascade of problems in the elderly is pretty common. They may have diminished pain mechanism, or they may actually have heightened pain mechanism. I had a lady who had a spiral fracture of her femur. Coincidentally, it happened while walking down a spiral staircase, which I thought was quite funny. But I kept that a little amusement to myself. She had a titanium knee, and I guess when she put one foot on a step and went to twist, it just popped her knee. And her pain scale was about a 1. She barely felt it at all. And yet you or I would be off the scale with pain with that kind of a femur fracture. They may have diminished equilibrium, and that puts them at higher risk of injury, of course, and falls, difficulty organizing information, decreased temperature, regulating mechanisms, impaired recall of events. I find, I get a history at the scene, and I always recap it in the back of the ambulance, just because you tend to get more information. I might even go over the history again before we arrive at the hospital, because every time you do it, you get a little bit more information from these patients. And they may have slow, voluntary, or automatic reflexes. Postural hypotension is pretty common in the elderly. In terms of the nervous system, they have a difficult ability to process information quickly and make decisions quickly. Brain atrophy puts tension on the arachnoid blood vessels, and that increases the risk of subdural hematomas, because those bridging veins between the inner table of the skull and the brain become stretched. My mom recently had a CT scan, and they were quite pleased that her brain was big. They said, I'm explaining this to my mom. I said, your brain shrinks with age, so the fact that you're telling your brain is big, that's a really good thing, because she had stroke-like symptoms, but it turns out she has Bell's palsy. My mom's 86, and she was on no medications at all until this incident, and she dances twice a week and DJs once a week, ballroom dancing. So seemingly minor head trauma can become a serious threat to life, and so we have to take minor bumps in the head in the elderly seriously. And there was a case in Barrie a few years ago where a guy sustained a minor head injury, no LOC, no altered LOC, just a goose egg on his head, and he refused hospital treatment. Apparently, my understanding is the crew did really, really well in their assessment. They were very thorough. They got a good assessment of capacity, and they did a good, legitimate sign-off on this guy. He was just adamant he was not going to go, and he died a few hours later. So this is the tough part, right? Any bump on the head, to me, for an elderly patient is going to warrant a transport to the hospital. And then, of course, if you look at things like they're on antiplatelets or anticoagulants, and it becomes a no-brainer. They're definitely going, no questions. Okay, so I got you guys thinking about retirement. It's good. In terms of mental status, delirium is very common in the elderly. And it's funny, I worked EMS for years without understanding what delirium was, and then once I understood delirium, I suddenly realized that probably 25 to 40% of my elderly patients had delirium. So delirium is an acute confusional state and develops in hours to days. It involves disorganized thinking, disorientation, sometimes agitation and hyperactivity, sometimes hypoactive, and is often there's some sort of underlying reversible cause. I'll talk about etiologies, but in my personal experience, one of the more common etiologies I seem to encounter for delirium is things like some sort of infection, like a urinary tract infection, commonly. But some CNS disorders that can cause delirium include hypoxia, tumors, head trauma. And head trauma can be really subtle, right? Because they bump their head, they don't remember bumping the head, they don't remember having the fall. The staff can't tell you anything about a fall, so you've got to do a trauma assessment, look at the head, look for subtle signs like mastoid bruising, periorbital ecchymosis. Periorbital ecchymosis would be a lot more obvious, but you got to look for things like mastoid bruising. Strokes, postictal states, infections. In terms of cardiovascular disorders or cardiopulmonary disorders, shock states, MIs, congestive heart failure, arrhythmias. And when we're talking MIs, we're talking about patients who present atypically, right? So these may be silent MIs, respiratory failure. Metabolic disorders include liver failure, so hepatic encephalopathies, anemias, hypoglycemia, hyperglycemia, acid-base imbalances, fluid and electrolyte imbalances, and medication abuse or misuse, sepsis, sensory deprivation, infectious disorders of any cause, alcohol, psychiatric disorders, and then other causes include dementia, Alzheimer's, Parkinson's. Medications in the elderly. Their distribution of drugs may be altered. So when we think about the pharmacokinetics of drugs, how they're absorbed and metabolized and excreted, that may be altered pretty dramatically in the elderly, and it's a very dynamic process, right, as their health slowly deteriorates and their liver function and kidney functions deteriorate. So metabolism may be decreased because of deteriorating liver function. Excretion may be decreased because of deteriorating kidney function, and so as a consequence, what used to be their therapeutic dose may actually be a slightly toxic dose for them now. So something to think about. Sensitivity may be altered. So 15% of the elderly have drug reactions versus 6% of the younger population. My mom doesn't tolerate drugs well at all. She's on Eliquis now because she's, actually I'm not even sure why she's on Eliquis, but it started because I thought she might have had a stroke, and now she might have an arrhythmia. But she had high cholesterol, couldn't take statin drugs. She, what else? There were some other issues, and just because she had adverse reactions to every single drug she took, and so there are very few medications that she takes. Drug use and misuse. I don't know about you, but I don't see a lot of sharing of medication. I mean, I've seen it from time to time, but I don't see a lot of sharing medications. I do see a lot of hoarding medications, and so when you're looking at trying to figure out what medications are currently on, the two things I found are important is, one, check the date it was last prescribed, because pharmacists will give the patients a list that includes every drug they've ever been prescribed since they were born, essentially. And so you've got to check that the drugs are current, that any antibiotics are current or they're expired and they're not on those anymore. And typically drug lists don't include things like the insulins and the puffers, so you have to ask about those separately. Self-medication may not be following the prescriptions. They may have improper drug storage where they're exposed to moisture. I'm just watching you type, MJ. If it's easier to use your mic, just feel free to hop on. They typically have a misunderstanding of the purpose of their drugs and the dosages. You ask them why they're on a particular drug. It's not often that they're actually able to tell you. I'm just going to try to read your text here, MJ. If I can. Hang on a second here. Let's see here. Everyone is 65 and under 25 should have full list of medication accessible from the pharmacy and share the piece of information because the government covers it. Population, yeah, fair enough. You just have to, look at that list carefully and see how accurate it is. Adverse drug reactions are common. Scheduling difficulties. There may be cost issues as well. I've seen younger patients with who've been unable to afford drugs as well. I had a guy who was in his early 40s who had an MI. It was the second MI, and after his first MI, he wasn't able to afford clopidogrel, and so he never took it, and had a second MI in the same vessel where he had a stent. So, very sad situation. There may be duplicate meds, maybe memory deficits, physical limitations. All of these things can lead to inappropriate prescription drug use. So, in terms of patients who present with signs and symptoms that are vague, I think it's important to consider that it may be due to prescription drugs. That's a potential cause. Got to be at least on your differential, on your radar. And any new symptoms could be due to drug therapy. Yeah. Any questions or comments about the elderly? Got everyone thinking about the retirement now? Start making investments early. Gotta have $1 million in your RSP to retire comfortably. You get up to 300,000, it'll grow on its own. But Andrew, you're welcome to hop onto your mic.
I was just making a joke about people investing in cryptocurrencies and all that stuff.
Oh yeah.
Seems to be the fad of the day.
Yeah, I work with a medic who's made a fortune on it, but
Yeah.
it's pretty volatile right now, from what I hear.
Yep.
All right, you guys, have a good morning, and I'll see you back at 11 o'clock.